So my name is Art Slutsky, and I'm going to chair a number of these sessions. I hope you have questions. You can see we're a little bit late. It's about 12:20, so I spoke to the other organizers. We decided to cancel lunch tomorrow. We're going to have 2 lunches tomorrow instead. I'm just kidding. We'll still continue. We'll go on for about 10 or 15 minutes. There's plenty of time. I'd also like to, I'm giving a talk tomorrow, so you'll see my formal conflict of interest, but I am a consultant to McKay, just so you know that. I think that's important for you to realize that. But as Hans mentioned earlier, this complete conference was funded by McKay largely, but all the intellectual input was done by the organizers with no input from McKay. So you have experts here on NAVA. I'd like to see if there's any questions. I'll start off with the first question, perhaps. And in fact, it gets to the point that Yuka brought up. Yuka asked a question earlier. And the question is, under pathologic conditions, is it better for the patient to control their own ventilation, their own pattern of ventilation, because that's what NAVA does, or is it better for the physician or the therapist to set the pattern of ventilation? Because that's really the critical issue here. Under pathologic conditions, is it better or worse? And I think Lucas got at that a little bit, partly by there's a couple of patients who you couldn't use NAVA, or you had to stop using NAVA. So can I ask some of the panelists to maybe address this? I think this is an important question in terms of NAVA. You want to start, Lucas?
Maybe I can just start. I think in general, it's a question of the trade-off. It's a question of the balance between harm and benefit. And I think we probably do not understand enough about harm and benefit. On the benefit side, I would maybe put conditioning of the muscles, so keep the muscles busy the way they are designed to be all life. And on the harm side, maybe I would put interactions with the hemodynamic system if it just doesn't work.
So Lucas, let me interrupt for a second, because I think you're right, it's a balance. But how do you decide in any given patient which way the balance is going? Like what do you measure? What do you monitor? How do you assess beforehand in a patient or during NAVA?
Well, that's probably what we do all day, just monitor the trends in parameters, in the important parameters. If you're looking at the hemodynamic system, all we can do is monitor which way it goes, which way the hemodynamic system develops. For example, our blood gases, if they go crazy, NAVA is not a mode to use. Or if the drive, like one patient in our study, we just couldn't use NAVA because the drive, the neuroventilatory or neural drive was uncoupled from the feedback system. So that's not a patient you want to use a neural drive ventilation.
Anybody else want to address it?
We did we are carrying out a study in NAVA with pressure support and weaning, and we observed that the group in the NAVA group had a higher proportion of being in an assisted mode of mechanical ventilation, but it didn't really affect the duration of weaning at that point. So we were partially satisfied, but we did not find any more complications in the NAVA group either.
I think actually we should leave the weaning. There's a whole session on weaning tomorrow, so we'll leave that. Jean-Christophe, you want to comment?
Only one comment from our ARDS patients. I guess we have to divide it in an early phase of the ARDS and a late phase. And to my mind, especially our very severe ARDS patients, in the beginning you need the control over the patient because you have to ventilate them highly protective. And especially if they have a severe capillary leak in the lung, if the underlying disease is not under control, I guess NAVA is not the best mode for it. So this is the phase where we use a controlled ventilation, that you have the complete control over the patient. But if you have the impression within the first 3-4 days the antibiotics work in the pneumonia, for example, and if the capillary leak decreases in the lung, that's the point, and the catecholamines decrease, that's the point where we change to NAVA. So if we have the underlying disease under control, then we go to NAVA. Yeah.
Follow-up question on that one is, when you say you take the control, do you turn off the patient at that stage, or do you let him still breathe as he wants?
We turn them off in the very beginning because of this severe capillary leak. Yeah, so especially if we use high-frequency oscillatory ventilation, we keep them in a very deep sedation level. But then, if we see it within 1 or 2 days that the patient gets better, then we turn off the sedation and then we let him wake up very quickly.
Which means that you maintain synchrony at all times.
Yeah, that's right.
Yeah.
Questions from the audience? Yep, Paulo.
I agree. In the early phase, first 48 hours is quite complex to think something different from volume control. But we try to be early in interrupting volume control and heavy sedation and sometimes even paralysis. And as I remember, once I called Christer, because the first time I was totally impressed. Beside early and late, there are different behavior related to the type of damage of the lung. There is a 25-20% of patients with ARDS that if you increase the NAVA gain, they increase the tidal volume. They don't decrease the ADI, what Christer mentioned. It's a relatively small group, but it's there. As far as I can see, they are predominantly an interstitial pattern at the scan CT, but I mean, it's just a gut feeling, nothing really scientific on that. Do you have the same type of experience? Does it happen to you that in some patient you can really keep down the ADI and if you increase the gain, it goes up? But then I also want to put a comment to Art's question. It's difficult to say what are the contraindications to NAVA, at least for me, unless we have the catheter in, which is kind of tautologic, it's closing the circle. It's really difficult for me to predict which patient. So because I have to save money for the administration, I make a selection. For instance, I don't use it in the head trauma, head injuries. I mean, now I learned that it's possible. But I mean, when I make a selection in those specific patients, I assume that I cannot use it. But he showed me today that I was wrong, at least in one case. So,
but going to your talk, if I understood correctly, in your neurotrauma patients or your traumatic cord patients, you used it in a lot of ways as a tool for monitoring, not necessarily for ventilation.
At the beginning, we would like to use it DI for monitoring to understand what is going on in our patient. But as soon as we put the catheter in the patient, we use it as another mode, and we develop appropriate expertise, and also it's very important. We develop an educational and training program for our nurses, so that we are able to implement this ventilatory mode for almost of the patient as soon as they are in partial ventilation mode.
Yuka had a comment. I wonder if you could get the microphone, Yuka. I think it would be, there we go.
One right here. Let me just, I'm getting a little bit confused on the answers of the panel. So let me just ask you, each of you, to make one quick comment on when you switch from whatever mode you are using before to the NAVA, what is the primary advantage that you are looking for or expecting? One major impact.
Okay.
Synchrony.
So if the patient has dyssynchrony, then you expect synchrony. Okay?
Yeah.
So what we find in the premature babies is because of the improved synchrony, they have lower peak inspiratory pressures because of the efficiency of delivering the assist. The premature babies are extremely asynchronous with a ventilator. So that brings down the pressures, and that's been shown repeatedly in them.
In fact, asynchrony is a topic we're going to do right after, well, we're not going to have lunch, but right after when we would have had lunch, we're going to talk a lot about asynchrony.
Just one comment for me, it's to develop a more physiological ventilatory modes and to have a good adaptation of the support to the clinical status of the patient.
We like to restore diaphragmatic activity as soon as possible, and so we try, and if we think it will be safe, we will continue. We think it's bad to have a diaphragm who is flat during 2 weeks.
I would try now on a patient that gets extra sedation to tolerate mechanical ventilation, in order to see if, when I switch to a synchronized mode, I could actually reduce the sedation level.
Actually, Christer, I'll answer for Christer. If the patient has a diaphragm, he uses it.
No, I think you have, as I said, I would put the other way around. I think that the biggest use of NAVA, I think, is the monitoring part, because you have all the tools. You can use NAVA, you can use pressure support, BiPAP, CPAP, whatever the modes are. But I think it's really the point, as Paolo pointed out, if I don't have a signal from the diaphragm, this is like the same thing. How do you know a patient has an atrial fibrillation if you don't have an ECG? It is really the biggest issue. Is I think you take more control of a patient if you know what he's doing. So if you don't know that he is breathing when you think he is not, or the opposite, like if you can't see what the patient is doing, I think that is the really, and from every study we've done, from any hospital in the world, we find patients who are not breathing, but the doctor can swear that they are, and there are patients who take like 25 breaths, there are patients who take 50 breaths, and you have no clue. And I think that's the biggest issue. You have no control of that vital. I think the EDI is a vital sign as much as the cardiac signal.
Christian, and then Jean-Christophe, or Jean-Christophe?
Just a point. I think that the question of Mr. Takala is very important. We have to define what we expect by using NAVA, because recovery from the initial disease to the end of the weaning process, success of weaning process, is a continuous process during which the priority will change step by step. I think that, for instance, synchrony, if synchrony is a main goal for NAVA, okay, but synchrony is probably not the priority during the initial phase of ARDS, for which the control of tidal volume may probably the high top priority, but it may change sometime just after. So I think it's very important to discuss result of NAVA in different circumstances. It's very important to understand how it works, but aside, we have to define what we expect with this mode of ventilation in this situation. And this is what is difficult to do for the routine practice. This is my point.
In addition to my comments to the ARDS, we have one patient group with COPD where we switch very early to NAVA, because in COPD we have this problem with the severe hyperinflation and the trigger problem. And there NAVA is it's fascinating if you see it the first time and if you switch the patient. And this is a patient group where we go very early to NAVA.
I guess it really gets to synchrony again. I mean, that's a big problem with COPD patients. Yuka.
Don't get me wrong, I don't want to spoil the party. But I mean, I've been interested on diaphragmatic EMG since the 80s. But I mean, the bottom line is now, all you say, everything is very fascinating, but so what? I mean, we really are. I fully agree with Christer. We need, I mean, this is a tool to increase our understanding. But at this stage, I must say I would have hard time going to a patient and say, you know, let me put in this catheter because then you will have a better synchrony. Synchrony for what? I mean, if you take Keith Hickling's permissive hypercapnia paper from the very early 90s.
I follow your point. However, I could make the same type of comment for 99% of the devices we used every day in ICU.
Well, that is part of the problem. We are increasing technology, and we need to have something more about it.
Yeah.
And that is in part it is unfortunate. In part it's unfortunate, but I think that let's not spoil this technology by claiming that it has big advantages before we prove it.
No, I think one thing for the advantages you are totally right about, but I would say like this. If you had been starting off with using the EDI as a controller signal, would anybody have reversed to control mode ventilation? Would anyone even thought of pressure support with a pneumatic trigger? I don't think so. I think we put like, where's the horse? Who goes with the horse, like rides to the work every day? You bike here in Holland, but I mean, who goes on a horse? Who uses a horse carriage because it's better for everything? I mean, you could bring anything with a horse carriage, but I mean, why do we use cars? They pollute, they are everything, whatever, they're technically nice, but as I'm saying, I think the development is here, and I think, again, from the point that we have seen in the studies, and we talk about synchrony in this case, machines like I will present this afternoon for Pradeep Mali from New York University, I mean, SIMV, called Synchronized Intermittent Mandatory Ventilation with pressure support, 2 synchronized modes. It doesn't work. Is there a recall? No. A little baby falls with a baby bike, hurts himself, another baby falls with a baby bike too. Major recall, take away all these things because these are dangerous. But I say, you are using a device that you don't know what it does to the patient, and I think that's wrong.
I think Yuka's point is a fair one in terms of real strong clinical outcomes. We don't know yet. I mean, this is still in the early stages. And certainly theoretically, there's some potential major advantages, especially, I mean, as I said, we're going to hear about synchrony later, but there's pretty good evidence that patients who are very asynchronous have poor outcome. Whether then synchronizing them improves outcome, we don't know, but it's a reasonable hypothesis. So one of the things I want to talk about, not necessarily, we're almost run out of time now, but we have a number of these, is what are future research studies? What's the future research looks like? And certainly good outcome studies would be very helpful. There's a number of people I've talked to in the audience who talked about they're using it, for example, mainly in neonates, I think, where they actually they're getting pressure from their parents, from the parents of the kids to use it. And I forget who mentioned that. Maybe we'll talk about that a little bit later. But I think we do have to think about, nice to have better clinical outcomes for sure. Those are tough studies to do. Long time, large number of patients, depending on what the clinical outcome really is. We have time maybe for one more comment, question. They're near the back, up the center aisle. There's a microphone coming.
Thank you. Kevin Carson from Dublin. I'd like to address a question to Jennifer, if I might. We use NAVA in a lot of surgical neonates. We found it particularly useful for dysynchrony or asynchrony. It's been very useful in those patients.
A little bit slower, sorry.
Sorry. We're using for surgical neonates, particularly with asynchrony or dysynchrony, that we found particularly useful. One of the things we've noticed, our EDIs are not as high as some of the examples you showed. They're more in the middle range and lower. But some of our very sick neonates have actually low EDIs rather than high EDIs we might have expected. I don't know whether you see that in your group as well.
Well, again,
there's a microphone right on your left. Yeah.
Thank you. I guess it depends on the numerous factors we've been talking about, which is the level of sedation, the level of assist they're on, whether or not they're post-op. But we're doing a monitoring study now and are just monitoring daily babies when they come into the unit, just before they're extubated and after extubation when they go home. And we find very low diaphragm activity levels on conventional ventilation when they're in the acute phase. They're very suppressible with conventional ventilation. So we've seen some babies with no activity at all, even though they're on conventional ventilation.
That's pretty much what we've seen as well. Yeah, thank you.
So thank you all. I think we better stop now or we really won't be able to have lunch.